Hi, everyone. It's Laurie White from the Greater Providence Chamber of Commerce, and welcome to episode number 82 of Chamber TV. And today we're talking about healthcare, all things healthcare. And we have a very special guest with us today, Kim Keck. And Kim is the president and CEO of Blue Cross Blue Shield of Rhode Island. But just as importantly and just as timely, Kim is the president and CEO-elect of the Blue Cross Blue Shield of Association Plans. So she will be departing Rhode Island in January, but not going too terribly far in terms of her new responsibilities as heading up the National Association that governs all of the Blue Cross and Blue Shield plans. So it's a very big job, very substantial amounts of responsibility, a tough job. So Kim, welcome to the program and congratulations once again.
Laurie, thanks for having me. It's great to be with you today.
Fantastic. So you have been the CEO of Blue Cross and Blue Shield since 2016 here in Rhode Island. And before that, you've had a long and distinguished career, most recently having been with Aetna for over 28 years or so. Lots of changes in the industry over the trajectory of your time as leading a major health insurer. So could you reflect a little bit about what you're seeing today and how that may be vastly different than when you first started your career?
Yeah, sure. Happy to do so. And congratulations, by the way, on your creativity during this pandemic. It's incredible what you've done with the chamber and having this be your 82nd episode. So good for you. Unlike your creativity, perhaps, and innovation in a 10-month time frame, if I think about over 30-ish years in healthcare, there's been some things that are constant that haven't really changed in a material way. And I'd say one of those things, Laurie, is the cost of healthcare. We've seen a lot of, I guess, on the positive, we've seen a lot of innovation and a lot of change with respect to access. So here in Rhode Island, we have, prior to the pandemic, so that may change as we make our way through COVID, but prior to the pandemic, about 95-ish% of Rhode Island residents were insured. So we have access to healthcare is something that I think Rhode Island should be very, very proud to lead the country in. Over many, many years, though, perhaps over my entire career, we really haven't got at cost containment in a really significant way. We've tried lots of different solutions over that time frame. Every few years, we try meaningfully different things, but candidly, there hasn't been a number of innovations and strategies that have really arrested the growth rate, if you will, the inflation rate of medical care in the United States. Even if we think, I'll just say one more thing quickly, if we think about the introduction of the Affordable Care Act now a decade or so ago in 2010, that did many, many things to improve access to care, but it didn't really tackle the affordability aspects of healthcare in the United States.
Yeah. So lots of things for you and your new role to sink your teeth into, and certainly complicated by the pandemic and all of the, the twin issues that are riling this country right now, including the public health crisis and racial injustice and other matters, housing included. So before we get into the COVID discussion, which I know you have a lot to share on that, let me just ask you, how are you? How's your family? How are you doing? How have you been managing through this very, very challenging time?
Oh, you know what? We're great. We're really, really lucky. So my daughter, was a senior in college when the pandemic closed down every school across the country, at least here in the Northeast. And so she came home at the time in March with two college seniors who didn't have a safe place to go for public health or personal health reasons of family members. So we had a full household of seniors trying to finish college at the kitchen table, which they did. And it was, in many respects, sort of for me anyway, and my husband, I think, really an enjoyable experience of having time with our daughter and some very, very close friends, dinner together every single night, broadband challenges during the day as seniors are trying to, walk around the place looking for the best signal, but we're all fine. We at Blue Cross Blue Shield of Rhode Island, we went home, full time, I think March 13th, which was a Friday. And we sort of said to ourselves, well, let's just experiment. Let's see how this goes. Our associates in Rhode Island are actually mostly work in the office associates, unlike other companies I've worked for in the past. So it was a really big experiment for us, and it's gone actually quite well. But thank you for asking. I hope you and everyone at the chamber are well and you're surviving this. I don't know if it's a twindemic. We sometimes say the additional pandemic on top of the two you raised is also the economic fallout, right? This economic crisis that's happening as we speak.
Absolutely. Yeah. So we have been home exactly the same amount of time since March 19th, although we do have a couple of people that go into the office every now and again to hand out PPE and other things for our members as part of the governor's initiative. But generally speaking, we are well, and we are keeping people informed through forums like this. So thank you again for taking time to talk with us today and go over some of the issues that I know people are concerned about and worried about during this particular time. So one of the things I was really interested in learning more about is your impressions and observations and the data that Blue Cross has been able to generate around the behavioral health fallout of COVID. I know this has been particularly difficult for the millennial generation, some statistics that you all have come up with about that. So what can you share about the emotional health of our neighbors, of our community, and what are some of the strategies that you're offering to help get us through that?
Yeah, it's a really good question, Laurie, and it's a crisis. It really is. And this isn't unique to Rhode Island, but it is pretty acute in Rhode Island. And so if we look at the Rhode Island population, I believe the last numbers I saw said something like over 45% of adults in the state of Rhode Island are saying that they're struggling with some sense, or I'm not sure the exact use of the words, it's at least anxiety, but it ranges from anxiety to, disorders of some kind, but related to depression or worse. And so this is a significant issue. It's one we have been focused on for the last probably 2 years, even before the pandemic. And unfortunately, I wouldn't say that we're keeping pace with the need of these types of services. So about 2 years ago, one of the things that Blue Cross did in the state was think about a number of things. First, think about how to eliminate sort of the barriers that people wanting to seek services for mental health might face, right? So sometimes those barriers could be financial barriers, like a co-insurance or co-payment. Sometimes it could be integrating care with their primary care office, and then seeing a clinical, a clinician could be a barrier of sorts because it wasn't necessarily an integrated experience. Sometimes it could be just not knowing where to go. And sometimes it could have been, and still sort of is, each of these is a little bit still true. Sometimes it could have been stigma. Mm-hmm. Right? For years and years and years, people didn't really talk openly about mental health needs. I think the pandemic has accelerated that conversation. But even about 2 years ago, we created a forum to start really opening about things like substance use disorder, including simple things like how to change our language around sort of addiction, right? As opposed to being addicted, having a patient suffer from substance use disorder, things like that. So simple stigma related issues. We've done and continue to do a lot of that work, Laurie, in terms of access, certainly working with the state and the great work that the state is doing through the BH Link and other programs. So we've continued to make accessible from integrating our care, from asking providers to follow up on visits, just to even incent them to say, okay, here's some patients that we're going to flag for needing unnecessary follow-up, particularly for mental health, paying for quality in mental health. But it's something that we are working with more, I'd say, collectively and collaboratively with many in the state, because this is a multidimensional issue. I'd say one other thing, and then I'll pause. So the Rhode Island Foundation, as you know, has put forth actually a pretty decent sized leadership group thinking about issues that affect our health, not just our healthcare, but our health, right? And so sometimes it may be access to housing, transportation, food, under this sort of assumption, which is true, that your zip code determines more of your health than your genetic code. So this long-term planning group has a specific subcommittee of it just focused on behavioral health. And so we'll be at Blue Cross collaborating with many, many different entities across the state to figure out, working from our data and potentially new sources of data, what are the new programs we need to put in place. But it's going to have to focus, in my opinion, on access. There's just not enough access right now for the people who need these services.
Yeah, so this is such a timely issue. I was reading the New York Times on Sunday, and big cover story about the degree to which millennials are having a hard time, more so than the baby boomers, and also how the Journal of American Medical Association talked about how people, particularly women, are drinking more alcohol. Yeah. So many, fallouts as a result of, what people are going through isolation, and, perhaps they've lost their jobs, or a spouse is sick, or whatever. Talk a little bit, if you will, to those employers, or even employees themselves, who are wondering, how might they access their own employer's health insurance regime and take advantage of programs and services that they might otherwise be reluctant to access during this time?
Well, first, I think it starts with having the conversation to this notion of being open and candid and reducing stigma to the extent that exists. I think it exists less and less, but to the extent it does, we would ask employers, particularly the folks who often buy health benefits for their employees, typically, not always, but typically are human resources executives. So these are executives that know how to have these conversations. They're steeped in not just benefits, but broader overall well-being of their population. So they can certainly work with their insurer on the programs that are embedded in their own insurance products to get access to mental health, which exist here in Rhode Island, but even outside of the state. So one of the things, Laurie, that we have seen in this pandemic is, of course, everyone talks about the use of telehealth, right? Because when our governor in March said, look, stay at home, everyone, we have a pandemic and we want to limit the spread and we want to sort of, isolate in place, that had a trade-off of people not necessarily going to seek services in person, including at their primary care or any other, point of care appointment, if you will, or surgery or the like. So the use of telehealth, and happy to talk about that offline, but went up very significantly out of necessity. And we at Blue Cross, as did other insurance companies, made lots of changes very, very quickly to make that accessible and to reimburse providers at the same rate as if they were seeing patients in the office. But that telehealth rate over the pandemic has actually come down in most categories of care, with one exception. And that exception is mental health services. So I think to this notion of what to tell employers and how to help with access, the telehealth option for behavioral health has continued to rise even above its peak in the spring when the pandemic first hit. And I think at Blue Cross, we have over 75% of our mental health visits are now either this way, video or phone call. And I think that is helping with this notion of, well, lots of things, access to care, meeting people where they are, but also to the extent there is some stigma and people feel more comfortable with using the technology, that seems to have been a great innovation, if you will, or at least a use of technology in a positive way.
Mm-hmm. Yeah, that makes a ton of sense, to be able to, sort of have the distance of the screen, if you will, and start to talk about some really highly personal issues, which, could be difficult for some folks. So let's talk a little bit more about some of the changes that you've seen as a result of the last 8 or 9 months during this pandemic. And what changes do you think are going to stick in the health insurance arena?
So this whole notion of telehealth for sure is going to stick. As I said a moment ago, we saw it come down quite a bit in some sectors of healthcare. So primary care visits at the peak of the pandemic, we probably had 55 to 60% of our visits all done through telephone or video chat. That is down probably to about 25% now. But pre-pandemic, it was in the low single digits, like 1 or 2% or something like that. So it will be a tool in the toolkit for sure. I also think there's a question about how to me, build on that, to integrate it with everything else. So it's not a one-off conversation, but it really is holistically thinking about how to manage patients' healthcare. And we've been on that journey in Rhode Island for many years. My predecessor started what I'd call this journey from fee-for-service to fee-for-value, to pay providers for managing the overall population, the health of their population or their panel, their patients, basically. That journey we've been on, probably a decade. But it's shown some positive results, but I think we're going to have to ask ourselves what the new models of care are. So it's population health, but it's not just sort of disaggregating, so we can holistically look at the overall, everything that might be going on with a patient as we have these kind of video chats and the like, that we're making sure we're incorporating. Okay, who did you actually see a specialist recently? Have you been to the ED? How do we integrate that and holistically understand what's going on? So I think the foundation has been built with telehealth, but I think we need to make sure the virtual connectivity is broader than just sort of one-off, if you will.
Yeah. So let's talk a little bit about how you are going to approach these issues in your new role as head of the Association of Blue Cross Plans. So tell us a little bit about Blue Cross Blue Shield Association and some of its core values.
Yeah, sure. So the association is many things. It's sort of an entity that probably has, I don't know, I'm going to say maybe 4 main purposes. One of the, which I can come back to this one, but one of the core accountabilities of the association is shaping and influencing policy at the national level. So Laurie, to your point, Blue Cross Blue Shield Association is the entity that represents 36 different Blue plans across the United States, just like Blue Cross Blue Shield of Rhode Island. We're a single state, not-for-profit, independent plan. So we are one of 36 plans that the association oversees, if you will. So one of the components is influencing and shaping healthcare at the national level, right? So we may have a new administration perhaps that wants to focus on healthcare, we'll see, but it would be shaping and influencing healthcare. The second aspect of the association, it actually is the insurer, if you will, for about 5 million federal employees across the United States. And then the third, I guess I'll combine the third and the fourth, is sort of this entity that oversees and sets policy and governance of how 36 plans across the country operate, and really tries to, in that vein, take the great work of 36 plans that are all working in our local geographies and sort of amplifies and connects their work. So to your question, would there be a national telehealth solution? How would that work? Can we sort of take what we're doing in Rhode Island and what another plan is doing in another 5, 6, 7 geographies and integrate it differently, or to get some consistency, right? The great thing about buying an insurance product from Blue Cross Blue Shield of anywhere is it works in 36 different, actually it works in 50 states in the country. So having that experience and connectivity and innovation work more collaboratively and constructively, if you will, and seamlessly is part of what my approach will be in the new role, including in telehealth and other ways we can lead through COVID. Because, after we get through COVID, or part of getting through COVID will be even the distribution of immunization. And so having sort of a standard protocol with that, working with local partners will be something that will be on my mind, as will the whole racial and inequities, because that's something that's true in Rhode Island, but it's also true in every state in this country. So looking at a platform, how can we more effectively lead in that space will be something on my mind as well.
Yeah, so that's a huge issue, the issue around the distribution of the vaccination. We had Dr. Ashish Jha on our program a couple of weeks ago, public health global pandemic expert from Brown University, the new head of the School of Public Health. And we were talking about, who's going to get the vaccine and how is it going to be layered on from a distribution point of view, and are there systemic inequities around the, who gets it first and how. I imagine this is a very, very poignant issue for the Blues.
Yeah. Even Laurie, even more fundamental, and I'm sure Ashish talked about that, is this whole notion of trust, right? That there are many people in the United States that don't even trust immunization or even some aspects of delivery of healthcare, and actually not for I'm not going to judge what the reasons are, but for perhaps valid reasons, right? They're valid to the people who don't trust because they've had experiences that may suggest that they need to seek care in other ways. So, one of the things I have heard Ashish talk about is, fundamentally we have to get it making accessible the key components of public health messages and why it's so important for certain populations, eventually all of us, to get this immunization. So we're thinking about ways we can, again, it's sort of back to that stigma issue, a different take on it, but there are many portions of the population that just don't trust immunizations generally, or even the healthcare delivery system generally. So we need to work on that holistically.
Mm-hmm. Is that more of a regional prevalence, would you say? There are parts of the country that would be more likely to want to default to that as a
probably on the margin, that's true, but there's more commonality than I'd like to admit, meaning disparities in healthcare unfortunately exist everywhere. And so embedded in that is this, not so much the immunization, but the actual experience in healthcare delivery. That is true really everywhere. Is it more true in some places? I think that's true. I don't know the data well enough by geography, but even in Rhode Island, we know some of the challenges exist in that regard.
Mm-hmm. One of the core themes that you just mentioned for the association is building on the innovations of the various plans, so each of the distinct 36 plans that are situated throughout the country, and building on the best practices and, perhaps regionalizing or collaborating. What in Rhode Island, no doubt, we are leaders in lots of different areas within this whole rubric. What is your plan to sort of, think through what Rhode Island is doing to be a leader and spreading that through the other plans?
I love the question, Lori. Because Rhode Islanders sometimes don't necessarily go quickly to what our strengths are. And I think there are a great many strengths in the state that we should more broadly be proud of in terms of what we've done in healthcare. And again, I don't take credit for most of these, but like I said, maybe 10 years ago, we started this transformation to what's called sort of value-based approaches to healthcare. Payers typically, so insurance companies typically working with physicians and hospitals to say, we don't want to pay you just for every service you do. We actually want to pay you based on an outcome or based on quality improvement or based on, do your patients get better, right? Not just that they saw you more often, but do they actually get better? We in Rhode Island, all insurance companies, I'd say Blue Cross has been a leader here, but others have been too, have been leading this work for 10 or so years. And I would say have meaningful improvements more in the quality aspects than the cost aspects, but getting this, what I'll call this transformation of fee for value completed in the state in a way that is not necessarily accessible to the patient yet. That's sort of the next, in my opinion, the next chapter in this book. There's sometimes this is accessible to the patient, but because there might be things like extended hours or in-home services or the like that are more integrated. But I think we need to build on the value-based transformation is one aspect. A second aspect is I keep mentioning cost, right? So the cost of overall health inflation has been something that has outpaced our wage increases forever. And so one of the things the governor did in Rhode Island about 2-ish years ago is convene a group led by Dr. Al Caros, Marie Ganem, who's the insurance commissioner. And actually, she asked me to partner with the two of them to lead a very, well, in Rhode Island, it's maybe big, 25-ish person group to think about ways in which we can collectively and collaboratively keep the cost of health and health care from growing at a rate that is no greater than how great the state grows, right? So the notion is if we're not careful, healthcare will consume all of our available resources of the state. But if instead we say collectively, the hospitals, the providers, the insurance companies, businesses take action across every aspect of healthcare, including things like pharmaceuticals. If we take action to say we are not going to let the cost of healthcare inflate at a rate greater than the rate we picked, 3.2%, we can over time actually start to make the right kinds of trade-offs to get at arresting cost growth. So that is something in the United States. I think there's only 3 states in the country that have done this. We may be the 3rd. So that would be one place I'd start to say, how do we think, do we need a national cost trend target, if you will, or not? Or how do we want to make those trade-offs? Because we can continue to spend more, but again, employers or individuals who are paying for health premiums, which are driven by health costs, are sort of saying, help, I can't do this anymore. So I think the value-based transformation is one. I think the cost trend work that we've been doing would be another. The work that we talked about in terms of the social determinants and how we're the group that Neil Steinberg is leading at the foundation that's getting at things like behavioral health and housing and meals and transportation and the like, how we integrate those into investments that we individually make and collectively so we can get at the better health of our residents. Those would be three areas I'd focus on: cost, value-based transformation, and this social determinants work.
Yeah. What about the notion of writing insurance policies across state lines?
Yeah, I don't think that is something that will have a material impact either way, because it depends. So when I used to talk about this topic a lot several years ago, we used to say Healthcare is just one of those things it's, even more local than politics, at least as local as politics. And so like, if you wanted to buy the lowest cost plan in the United States, you might go to a county in Utah and get the lowest insurance premium that you could find anywhere in the United States. But unfortunately, that premium is driven by the cost of care in that state. And, oh, by the way, the doctors and hospitals in that state. So I know it's an extreme example, but if anyone wanted to sell across state lines to say, and I'm an employer in Rhode Island, I want to buy that product in Utah, my employees generally don't want to go to Utah. Now, again, if we're in Massachusetts and Rhode Island, that's a little bit different, but typically our cost of care in Rhode Island is not terribly different than Massachusetts. Massachusetts is more expensive for sure, but we're still in the top 10 in the country. So we don't want to go to they're either number 1 or number 2, and we're 7, 8, or 9 on any given year. But I don't think, Laurie, that that's the most meaningful policy tool we have in the toolkit. It's interesting, but I don't really think it gets at solving an issue.
Mm-hmm. Well, the thought was, you hear people say, well, health insurance is all around scale.
Yeah.
And being able to aggregate the dollars and use the negotiating power of a larger premium base. So that's obviously something that is not necessarily on your agenda for day 1 or day 2 or day 3 in the new role. What are your thoughts around the aggregating of various systems? As an example, we have the Care New England lifespan proposed consolidation, and these types of things are happening all across the country, not just here in Rhode Island. So if the scale around insurance isn't necessarily a place we want to go, what are your thoughts around the aggregating and the scaling of various large institutional providers?
Yeah, it's a great question. And it's a conversation I've been having with leaders in the state, Dr. Babineau, Dr. Finelli, and even Chris Paxson at Brown, right, looking to create this integrated academic medical center in the state. And I understand their objectives. I think one of the things that we're asking is a lot of questions about if, in fact, there is this consolidation, how do we mitigate what happens really in every other state in the United States? And that is costs go up fairly significantly and quality does not, right? Sort of the premise of your question, Laurie, might be, do these types of transactions create scale that's used in a way that's only about garnering more price if you're a hospital, for example? The literature says that's what's happened. I believe we have to take action in Rhode Island and can, based on our unique state, to mitigate those types of outcomes, but they won't happen naturally. So, it's sort of technical, but in the state of Rhode Island, in addition to the work I articulated that is unique, we also have OHIC, which is unique, and OHIC has certain regulations. This is Office of the Health Insurance Commissioner, rather. The person is Marie Ganem. We talk about it as an office all the time. She has a team, she has a role, and one of the roles that she plays is regulating insurance companies, and embedded in that is a regulation that says we can't pay hospitals above a certain rate of inflation. And so in any case, the short answer to an otherwise longer framing is, I think there are ways we can mitigate what happens in every other state. But if we're not careful and we're not thoughtful and we don't take explicit action, the consolidation, if it mimics what happens in every other state, will increase costs quite a bit and will not increase quality. But again, there's some caveats, and experts like Ashish Jha and others might know what some of those levers that we could use to mitigate those negative outcomes.
Yeah, certainly a lot of discussion around whether, like, small community-based hospitals, whether they can survive in an era like this.
Right. I think that's true. Sorry, go ahead.
Yeah, no, go ahead. So the small standalone community-based hospital trying to go it alone and deliver care to a community, where does that look long term?
Well, I think the question is maybe even more broad than that, is sort of what's the role of hospitals in the future, healthcare system, and do we create the right ways in primary care offices and outside of primary care offices to really get at health and healthcare? That means we only go to the hospital for the things that the hospital is really good at. And, if we look at our statistics pre-pandemic, there's a whole another chapter of this story being written as COVID-19 unfolds. But if we look at our statistics over the last several years about patients going to the emergency room in the state of Rhode Island, we have a huge amount of people who go to the ER for things that really don't have to be done in the emergency room. But if we really had a system designed with the right access points in the right places in the delivery system, I think this notion of what happens in a community-based hospital, I don't know, it might be different depending on what the real needs. And I think we have to go through an assessment and say, what are the right things that have to be done in a hospital? What scale do we need? What investments do we need? And it'll be a tricky set of issues to wrestle with.
Good thing you're a mathematician by training.
I'm a little rusty, but
well, remember the days when we used to call the hospital ER the accident room? Do you remember that? Right. A very benign term. So, we're going to go to the accident room because, we have a cut or something. So sometimes traditions die hard in that respect. You mentioned, the first thing you mentioned in your 4 planks for your new role as head of the Blue Cross Association is advocacy. And that's definitely one of the leading focuses for organizations such as yours. So the advocacy role, national, international, local. So in that regard, what are your thoughts about the future of the ACA?
Well, I think some of it will be determined on, who wins the White House as we sit here pre-election. Hard to know. The association staff has already been working with candidate Biden's healthcare platform, and I think to be determined on what that platform is. But the element that I think is true is that Vice President Biden, if he's elected to the role, wants to build on the Affordable Care Act. And there are several things that I think are top of mind for that potential administration on how to fortify, if you will, the Affordable Care Act. If the Trump administration does in fact win this week and stays in office, I think that the Affordable Care Act may have some more challenges, right? We know the Supreme Court is hearing the Affordable Care Act case on the 10th. So I think that's next week, next Tuesday, I think. And we won't know the outcome of that case likely until the spring of 2021. I think one of the things we can feel pretty good about Rhode Island, it's not perfect, but in Rhode Island, a lot of the Affordable Care Act was codified into state law. And so there are some protections in the state of Rhode Island that will make the potential disruption if the Affordable Care Act were to fall, lessen the blow. They're not perfect because one of the things that's a key pillar of the Affordable Care Act is federal subsidies, money from the federal government. And that funds a lot of the access to things like Medicaid expansion or even subsidies for people who can't otherwise afford to buy health insurance on their own. Without the federal dollars, it's very hard to make any of these programs work. But there are some nuances to the state law that would mitigate on the margin, mitigate for the employers in particular, some of the benefits of the Affordable Care Act. So at the association, we'll be certainly, to the extent Biden wins, working with him on what those next elements of fortification, if you will, on the Affordable Care Act could be, even with the Trump administration, right? The association has also had a lot of conversation about what healthcare policy could look like. And I think that's probably one of the reasons the president speaks so so readily about no pre-existing conditions, right? This notion pre-Affordable Care Act, insurance companies, I don't think Rhode Island was a state that allowed this, but I wasn't here at 2010, but there were some states that allowed insurance companies essentially to not sell you insurance if you had asthma, a pre-existing condition, right? The Affordable Care Act outlawed that in 2010. And of course, it's a very popular feature of the Affordable Care Act because, it turns out millions and millions of Americans have pre-existing conditions. So the president has said that's part of his platform. It actually happens to be part of the Affordable Care Act. If we could build upon that, that would be great. I think, hopefully we'll know more, hopefully soon, hopefully in the days or weeks after the election.
So you are ready to mobilize. You will be departing your role as CEO of Blue Cross and Blue Shield of Rhode Island and officially moving into the new position on January 4th. So tell us about your interim successor and what we can look forward to as we turn the page on leadership.
Sure. So the board of directors of Blue Cross and Blue Shield of Rhode Island named Michelle Lederberg as interim CEO. Michelle is a 20-plus year veteran at Blue Cross here in Rhode Island. I believe, she's a Brown University grad. I know that for sure. I was going to say I believe she stayed after Brown, but she actually did a couple of other stints, I think, but has been leading critical functions of Blue Cross for many years. So she's currently the chief administrative officer of Blue Cross. She's also general counsel. So I don't think anything changes materially in the short to intermediate term, right? I think the strategy that the company has was approved by our board of directors last month. I think it was October. I think Michelle knows the culture of the company. She knows the stage. She knows the policies that the governor and her team are leading in terms of these cost issues. And I really think and hope it will be as seamless as possible. I am looking forward to somehow getting to Chicago for January. I'm not exactly sure how. I was even thinking, look, these are not real issues. These are not real issues. They're just minor inconveniences. But my husband and I were thinking about taking a trip to Chicago to see some real estate. We think we want to buy an apartment or even rent. We don't even know. We don't really know Chicago at all. And so I was looking at what the COVID restrictions are, and if I have to quarantine for 2 weeks, if we travel to Chicago before I could leave someplace. I'm like, wait, for us to get a real estate trip for 2 days, I have to be there for 2 weeks before I can actually see something. So yeah. I think we're going to be using a little bit of the technology. Yeah. January 4th would be my guess, but I feel a little awkward about that. I want to be in person. I want to be able to see people, but it turns out the pandemic has other ideas.
Yeah, well, you can do virtual real estate tours and, the whole 360 model. And
yeah, we've done a few of those.
It's going to be cold on the lakefront there. So at least that's something that perhaps you can mitigate. So I want to thank you, Kim, for the work that you've done as a truly authentic and accessible leader at Blue Cross. And you have been a very valued member of the board of directors of the Greater Providence Chamber of Commerce. So we have all really enjoyed working with you on so many issues, including, data and interoperability. You and I worked on some of those issues with the Quality Institute and quality of care and using data to better inform many of the decisions that we make. But we will absolutely miss you, but we know that you are not going too far and that you are going to leave an indelible mark, not just on Rhode Island, but also as you continue to do work nationally and deploy your great talent. So is there anything that you'd like to share as we get to the top of the hour here?
I would just echo my thanks and appreciation, Laurie, for your leadership in the state. It is really unparalleled. And I think the fact that, as I said during our conversation, maybe
So that concludes our conversation with Kim Keck, who is the CEO of Blue Cross and Blue Shield of Rhode Island. We had a little bit of freezing of the bandwidth there as we were winding down our discussion, but I know that she had a lot to share relative to so many issues here in Rhode Island, the social determinants of health and access to care and quality care and ways to arrest and bend the cost curve associated with health insurance. So we wish her well, and we also look forward to working with her interim successor, Michelle Letterberg, and we'll be sure to keep everybody informed as the days and months go by relative to the state's response to the COVID-19 pandemic in ways that we as employers can help to serve our community and also to help serve our employee base as well. So thanks again for joining us, and thanks to Kim Keck, and we'll see you next time. Bye-bye.